Hello everyone. Today's lecture will be on orofacial pain. I will be talking on the type and causes of orofacial pain and management of this pain. Orofacial pain disorders are highly prevalent and debilitating conditions involving the head, face, and the neck. These conditions represent a challenge to the clinician since the orofacial region is complex and therefore pain can arise from many sources. The clinician needs to have solid knowledge of the pain conditions that arise from these structures for proper diagnosis, and a multidisciplinary approach of management is strongly recommended. So what are the causes of orofacial pain? Orofacial pain can be due to a number of causes: local disorders, possible psychogenic causes, neurological disorder, vascular disorder, and referred. Local disorders include teeth and supporting tissues, meaning odontogenic origin. It can also due to jaw pathology, disease of the maxillary antrum, and pathology of the salivary gland. For possible psychogenic causes of orofacial pain, it can be due to chronic idiopathic facial pain, or also known as atypical facial pain, burning mouth syndrome, and temporomandibular pain dysfunction. Neurological disorder also can contribute to orofacial pain. Example of these disorders are idiopathic trigeminal neuralgia, malignant neoplasms involving the trigeminal nerve, glossopharyngeal neuralgia, and herpes zoster, including postherpetic neuralgia. Vascular disorder also can lead to orofacial pain. Example of these disorders are migraine, periodic migrainous neuralgia, and giant cell arthritis. And finally, orofacial pain can also be due to referred pain from other places. For example, pain from nasopharyngeal area, pain around the ocular or eye region, and pain due to angina. So, diagnosis of orofacial pain. The history is the most important means of diagnosing orofacial pain. So, in order to differentiate the widely disparate causes, it is essential to determine the key points about the pain. So, these are the important key point about pain. We need to know the location of the pain, the character of the pain, the duration, the frequency and periodicity, the precipitating, aggravating, and relieving factors, and any associated features to the pain. So, location. A valuable information can be obtained by asking if the pain is localized or diffuse and watching the patient's reaction. For example, patients frequently point with one finger when describing pain of dental causes or trigeminal neuralgia, but atypical facial pain is much more diffuse and may radiate across the midline. Secondly, the character of the pain. Patients should be asked about the severity and character of the pain. That is, whether the pain is sharp, dull, aching, throbbing, or shooting pain. We need to ask the patient to rate the pain severity on a scale of 0, meaning no pain experience, to 10, where most severe pain that the patient has experienced. Disturbance of the normal sleep pattern by pain is also useful in the assessment of the severity. Duration of the pain. The average duration of each episode may help diagnosis. For example, pain from exposed dentin is fairly transient, lasting only for seconds following application of a stimulus, while the pain from pulpitis lasts for a much longer period. Trigeminal neuralgia is a brief lancinating pain lasting up to about 5 seconds, although some patients report a persistent background less severe pain, more of a dull ache. Migrainous neuralgia typically lasts for about 30 to 45 minutes, and chronic idiopathic facial pain is typically persistent. We also need to know the frequency and periodicity. We need to determine whether the pain occurs at specific times or is related to specific event. The pain of temporomandibular pain dysfunction syndrome may be more severe on waking if this is associated with nocturnal parafunctional activity such as clenching or tooth grinding. The pain of sinusitis is often aggravated by lying down. The periodic membranous neuralgia frequently disturbs the patient's sleep at a specific time each night. We also need to look at the precipitating, aggravating, and relieving factors. It may be necessary to resort to leading questions to ask if there is any precipitating factors involved. For example, heat often aggravates dental pain. Touching a trigger zone may precipitate trigeminal neuralgia attacks. Stress may worsen atypical facial pain, and alcohol may induce episode of migrainous neuralgia. And the last thing that we need to know is about any associated features to the pain. Some type of pain may be associated with other features which are helpful diagnostically. The swollen face, for example, is common in dental abscess. Nausea and vomiting is common in migraine. And nasal stuffiness or lacrimation is common in migrainous neuralgia. Okay, this is the algorithm of chronic orofacial pain. If the pain is associated with dental cause, so we should be looking at any etiology of caries, trauma, periodontal tissues, or periodontal disease or cracked tooth. If the pain is not due to dental cause and the pain is lancinating in nature, it could be due to trigeminal neuralgia. But if the pain is not lancinating, it could be due to atypical facial pain, oral dysesthesia, referred pain, TMJ pain, or postherpetic pain. So this algorithm can be very helpful in determining the causes of orofacial pain. Now let's look at the causes of orofacial pain. First, the local cause. Odontogenic pain is the most common pain for orofacial region. Then we have mucosal pain. Mucosal pain can either be localized or diffuse. Localized mucosal pain is usually associated with a mucosal break, either an erosion, meaning a partial thickness loss of epithelium, or ulcer, meaning a full thickness loss of epithelium. Diffuse mucosal pain may be due to infection or is a systemic underlying deficiency state or other factors and is usually described as soreness or sometimes burning. Management of mucosal pain is either to treat the underlying disease or by given medication. Salivary gland. Pain from salivary gland disorder is mainly caused by ductal obstruction, sometimes due to infection, a tumor, or cellulite. The pain is usually localized to the affected gland, may be quite severe, and may be intensified by increased saliva production, such as before and with meals. Examination may reveal a swollen salivary gland, sometimes with tenderness and or a degree of trismus. Management for pain from salivary gland disorder, it can either be medical intervention, for example, antibiotic and non-steroidal anti-inflammatory drugs for infected or inflamed gland, and surgical intervention in the cases where there is presence of tumor or cellulite or stone in the gland or duct. Disease of the paranasal sinuses and nasobearing, which can cause oral facial pain, include sinusitis and tumors, which can remain undetected until they have reached an advanced stage. Any suggestion of a discharge from the nose or obstruction to breathing, cheek swelling or numbness or tingling of the upper lip should be taken seriously as they may herald an antral carcinoma. So management for orofacial pain originating from the paranasal sinuses is either medical and surgical intervention. Medical, for example, the use of antibiotics, antihistamine to treat infection and inflammation of the sinus, and surgical intervention in case of cancer or tumor. present in the paranasal sinuses. Sometimes we do have pressure on mental nerve. This is where there is dehiscence of the mental nerve as a result of resorption of the alveolar ridge. This can uh, lead to pain due to pressure from a denture. So management for this type of cases is surgical intervention. This is where we can do a relocation of the mental nerve. Relocation of the mental nerve in order to avoid pressure from the overlying denture. Okay, next we look at the orofacial pain due to referred pain. Referred pain can come from the neck, heart, lungs, eyes, and the ear. For the neck, cervical vertebral disease, especially cervical spondylosis, very occasionally causes pain referred to the face. The heart, in patients with angina, the pain usually affects the mandible, is initiated by exercise, and abates quickly on rest. Pain referred from the lung. Orofacial pain originating from the lung cancer is a well-recognized entity and can mimic, for example, TMJ pain dysfunction syndrome. Styloid process. Referred pain from styloid process, for example, in Eagle syndrome, which is a rare disorder due to an elongated styloid process. This elongated styloid process can cause pain on chewing, swallowing, or turning the head. The eyes, pain from the eyes arising, for example, from disorder of refraction, retrobulbar neuritis, or glaucoma can radiate to the orbit, maxilla, or frontal region. And finally, referred pain from the ear, for example, middle ear disease may cause headache or pain in the TMJ region, temporomandibular joint region. Okay, the other cause of orofacial pain is from neurological or neuropathic cause. Sensory innervation of the mouth, face, and scalp depends on the trigeminal nerve, so that diseases affecting this nerve anywhere in the course from the orofacial region to the brain can cause orofacial pain or indeed sensory loss, sometimes with serious implication. Any lesion affecting the trigeminal nerve may cause pain, often with physical signs such as facial sensory or motor impairment. Such causes include trauma, cerebrovascular disease, demyelinating disease, for example, multiple sclerosis, neoplasia, for example, nasopharyngeal or brain tumor, or infections such as herpes zoster. Trigeminal neuralgia is an example of neuropathic pain. This is a chronic paroxysmal neuropathic pain condition that is described as a severe, lancinating, and electric-like unilateral pain. It is localized most often to the second and third distribution of the trigeminal nerve, meaning V2 and V3, intraorally and extraorally, and can present in both distribution at the same time. There is usually a trigger zone in the trigeminal distribution, which, when stimulated, can result in an excruciatingly painful attack. The pain attack lasts seconds to minutes, and numerous pain episodes can be present daily. The etiology of trigeminal neuralgia is often related to vascular compression that may result in focal demyelination. The superior cerebellar artery compression on the trigeminal root has been shown to be responsible for attacks of trigeminal neuralgia pain. However, non-vascular compression by a cerebellopontine angle neoplasm, such as acoustic neuroma, meningioma, and neurofibroma, have also been shown to result in trigeminal neuralgia. A cranial nerve examination can demonstrate other neural deficit that may be present due to a mass pressing on the trigeminal root. MRI and CT scan of the brain should be requested in order to rule out any intracranial pathology. How do we manage trigeminal neuralgia? Trigeminal neuralgia is often an intermittent disease with apparent remission for months or years, but recurrent is common, and very often the pain spreads to involve a wider area over time, and intervals between episodes tend to shorten. So management can either be medical or surgical treatment. Medical treatment involves the use of drugs. For example, carbamazepine. Carbamazepine is the main anti-convulsion used to control trigeminal neuralgia. It prevents attacks in 60% of the patient. Carbamazepine must be given continuously, prophylactically for a long period of time. Carbamazepine is not an analgesic, and if given when an attack starts, it will not relieve the pain. Dosage-wise, typically we should give 100 milligram doses twice daily for 2 weeks, then 3 times daily, increasing by 100 milligram every 3 days to maximum of 1000 milligram per day. Most patients respond to 200 to 400 milligram 3 times daily. Sometimes a combination of carbamazepine and baclofen can also be useful in the treatment of trigeminal neuralgia. Other medications that can be used in the treatment of trigeminal neuralgia include clonazepam, gabapentin, oxcarbazepine, valproate, topiramate, and pregabalin. So we can do what we call a peripheral surgery. This involves deliberately interrupting nerve conduction in a division or branch of the nerve. Example, we can do local cryosurgery. We can inject glycerol or streptomycin around the mandibular or mental foramen. We can also do a peripheral neurectomy of whole division using alcohol or phenol, and we can also do a radiofrequency thermocoagulation. We can also do open surgical procedure. For example, we can do a microvascular decompression of the trigeminal root. Next, we can also do percutaneous approaches to the trigeminal gangliolysis by heating, compression, or chemical. And the other surgical methods that can be used is the stereostatic gamma knife radiosurgery. The other example of neuropathic orofacial pain is herpetic and postherpetic neuralgia. Herpes zoster is often preceded and accompanied by neuralgia. Neuralgia may persist after the rashes has resolved. Postherpetic neuralgia is pain in the trigeminal region that may follow an attack of zoster. It causes continuous burning pain. Analgesics rarely relieve postherpetic neuralgia, and treatment is usually difficult. So management include the use of antidepressant, for example, amitriptyline, the use of gabapentin, oxycodone, carbamazepine, and we can also try transcutaneous electrical nerve stimulation pens. Next, we will look at the vascular origin of orofacial. The first example is migraine. Migraine is a headache that can cause severe throbbing pain or a pulsing sensation, usually on one side of the head. Migraine is usually associated with photophobia, nausea, and vomiting. Pain character is throbbing, usually affect during the daytime. Precipitating factors, food. Food is the precipitating factor. How do we manage migraine? We can use certain medication, for example, sumatriptan, clonidine, and ergot derivative. Migrainous neuralgia is the other vascular origin for orofacial pain. This is less common than migraine, but more likely to cause orofacial pain. The pain is unilateral, occurs in attack, is burning and boring in character, and usually localized around the eyes. Generally, the attack commences and often awaken the patient at the same time each night or in the early hours of the morning, hence the term alarm clock headache. Migrainous neuralgia may be associated with profuse watering and congestion of the conjunctiva, rhinorrhea, and nasal obstruction of the affected. The attack usually ends in less than 1 hour. Attacks are sometimes precipitated by alcohol. How do we manage migrainous neuralgia? The use of certain medication, for example, sumatriptan, beta blockers, indomethacin, and oxygen inhalation has proven to be effective in the management of migrainous neuralgia. Okay, next we will be looking at the psychogenic causes of orofacial pain, atypical facial pain. We can also use certain medication, for example, amitriptyline, clonazepam, gabapentin, and nortriptyline. Surgery is not appropriate for the treatment of atypical facial. Burning mouth syndrome basically it is usually bilateral and it can cause moderately to severe pain, burning, scalded, and tingling pain. It is not worsened by eating, rather it is often relieved by eating and drinking, and rarely there is spontaneous remission. Certain medication can be used to treat burning mouth syndrome. These include the use of amitriptyline, clonazepam, gabapentin, nortriptyline, and trazodone. The next psychogenic origin for orofacial pain is temporomandibular joint pain dysfunction syndrome. This refers to a common triad of jaw clicking, jaw locking or limitation of opening, and pain. TMJ pain dysfunction syndrome mainly affect the younger people. Etiology can be due to trauma, muscle hyperactivity, and possible dental causes, for example, abnormalities of the dental function. Clinical features of TMJ myofascial pain dysfunction. Symptoms are highly variable, but dysfunction is characterized by recurrent clicking in the TMJ, limitation of jaw movement, and the presence of pain. Diagnosis is mainly on clinical ground. CT scan, MRI, or OPG can be useful. Management. How do we manage TMJ pain dysfunction? Management aims at control immediate pain, also aim at lowering the psychological stress, meaning reassurance, and also aim at eliminating any temporomandibular joint damage. So the treatment include physical, medical, psychological, and also surgical approach. Physical approaches, these include occlusal adjustment if there is any occlusal abnormality, occlusal reconstruction, for example, the construction of denture for partially edentulous patient, the use of occlusal soft plane, immobilization of the jaw, muscle exercise, and the use of mandibular orthopedic repositioning appliance, for example, Michigan appliance. Medical treatment include proper rest, the use of heat and cold pack, the use of transcutaneous electrical stimulation, the use of non-steroidal anti-inflammatory drug, and the use of muscle relaxant. We can also use antidepressant to treat TMJ myofascial pain dysfunction. We can also inject certain medication into the joint, for example, in TMJ arthrocentesis. We can also do trigger point local analgesic. This is periarticular local analgesia. And we can also inject intra-articular corticosteroids. Now let's talk about TMJ arthrocentesis. Yeah, arthrocentesis arthrocentesis is a simple, minimally invasive technique that can be used instead of a more invasive procedures in patients with pain that fails to respond to conventional conservative measure. TMJ arthrocentesis procedure bridge the gap between surgical and non-surgical treatment, and the success rate is about 85%. Arthrocentesis defined as the lavage of the temporomandibular joint without viewing the joint space using sterile needles and sterile irrigants so as to reduce the pain by removing inflammatory mediators from the joint or to increase the mandibular mobility by removing intra-articular adhesions by means of hydraulic pressure from irrigation of the upper chamber of the temporomandibular joint. It is a technique utilizing the insertion of two needles into the upper joint compartment, permitting effective lavage of the joint. Okay, for the two needle technique, this is the classical technique to perform TMJ arthrocentesis, utilizing double access to the joint cavity. This technique, as mentioned, use two needles, one for injecting and the other one for aspirating the solution. For this two needle technique, a straight line is drawn on the skin, joining the middle portion of the tragus of the ear to the outer canthus of the ipsilateral artery. Right. So, if this is how we perform the TMJ arthrocentesis, this is the first needle, which is 10 millimeter anterior to the tragus, and 2 millimeter below. And then this is the second needle for aspirating of the solution in the joint. Okay, this is 20 millimeter anterior to the tragus point and 10 millimeter below the cantotragal line. So the solution will be administered through the first needle and will be aspirated out via the second needle. Okay, this is the diagrammatic representation. This is the first needle. The first needle, the point is 10 millimeter from the tragal point and 2 millimeter below the cantotragal line. And this is the second needle to aspirate the fluid from the superior joint compartment, which is located 20 millimeter anterior to the tragal point and 10 millimeter below the cantotragal line. Right, so this is the clinical photos, okay, of the first needle, and this is the second needle to allow drainage or aspiration of the fluid that has been administered into the superior joint compartment. The other surgical procedure that can be done to treat TMJ myofascial pain dysfunction when non-surgical treatment is ineffective is TMJ replacement. So if intra-articular disease progresses to the end stage, autogenous or alloplastic joint replacement may be required. Autogenous meaning we can use the iliac bone graft to replace the temporomandibular area, or we can use alloplastic joint to replace the temporomandibular joint region. The goal of TMJ replacement is to return the mandible to correct form and improve its function. However, the translational mandibular movement is often lost because the lateral trigeminal muscle is sacrificed when removing the diseased condyle. Therefore, the mandible can only rotate. The intra-articular end-stage TMJ pathology results in degradation of the physiological function and form of the mandible and dictates the need for temporomandibular joint replacement. In alloplastic TMJ replacement, osseointegration of an implant fixation into the bone is needed for long-term stability and success. The condyle ramus component is fixated with screws into the lateral ramus of the mandible, while the fossa component is mounted with screw to the zygomatic process of the temporal bone. These compartments articulate with each other to develop improved function and form of the end-stage diseased temporomandibular. So this is example of temporomandibular joint replacement where the diseased condyle has been resected together with the lateral trigeminal muscle. So movement allowed is only rotation of the condyle, but not translation. So once the condyle has been removed, here we are using alloplastic material to replace the condyle. So the fossa component will be placed first. It will be fixed with screw to the articular eminence, and then the condyle ramus implant will be placed, and a few screws will be attached to the plate to secure the condyle ramus to the lateral border of the mandible. So the alloplastic joint and the fossa allow movement of the movement of the joint to take place. Okay, so my last slide, the conclusion of this lecture. Orofacial pain is a frequent form of pain perceived in the face and or oral cavity. It may be caused by disease or disorders of regional structures, dysfunction of the nervous system, or through referral from distant sources. The incidence and prevalence of orofacial pain in the general population is very high. Care and emphasis should be placed on correct diagnosis and treatment rather than on symptomatic management. So with that last slide, I thank you for your kind attention. Thank you.